when a question of hypertriglyceridemia comes up, there are three major questions which are asked. Is the Indian diabetic patient uniquely placed in a high cardiovascular risk category? What is the evidence that hypertriglyceridemia increases CV risk and other risks? And does lowering of triglycerides reduce cardiovascular risk? Asian Indians, the burden of diabetes in India is huge, and much more than that is the burden of CAD in Indian diabetics. There is a twofold higher risk in Indians in the urban region and fourfold higher risk in Indians as compared to Americans and Chinese. But the more disturbing thing is the prematurity of CAD in Asian Indians. Study done in UK shows in the age group of 20 to 29 years, Indians had a 3.3 risk ratio compared to the whites of 1.36. And at the age of 30 to 39, the Singapore study showed Indians have a 12.5 risk ratio of CAD compared to the Chinese 3.0. More than 50% of deaths in 2013 in the diabetic population in India were in the age group of less than 60 years. 25% under the age of 40 years. This is the burden of Indian diabetics in other countries. They are much more compared to the whites in Canada and England, much more than the Malays in Singapore, and much more than the blacks in South Africa. 40.9% Asian Indians, Malays 27.9%, and Chinese only 11.0% risk of IHD. CAD is prevalent, more incident and more hospitalization and more mortality. There is greater severity of CAD, greater prematurity of CAD, higher prevalence of diabetes. The high cardiovascular risk is due to higher prevalence of emerging risk factors, and these are the increased lipo-A, homocysteine ApoB, triglycerides, HDL, fibrinogen, PA, increased small dense LDL, and increased VLDL, and my topic is triglycerides. This is a very simple diagram to show you the good, the bad, and the ugly lipoproteins. These are all lipids in the blood. The good ones are the HDL, the bad ones are LDL. The triglycerides are actually the ugly ones. And the lipoprotein A is the deadly one, and the total cholesterol is all the cholesterol in all the lipoprotein particles. If you look at the last line, you will find that lipids plus proteins is lipoproteins, and all these lipoproteins are present in the bloodstream. This is a very good picture. I would like you to look at it and try to imprint it in your mind. It's a very simple picture which shows the lipoproteins in the bloodstream. In the lumen, you will find the chylomicrons, the VLDL, chylomicron remnants, IDL, LDL, and HDL. And as you can see, the white ones are the triglycerides and the yellow ones are the cholesterols. So both triglycerides and cholesterols are present in the lipoproteins, and the content of VLDL, chylomicron remnants is high in triglycerides and in IDL and also in LDL. If you look at the last line, the non-HDL cholesterol is total cholesterol minus HDL cholesterol. This is how we've always been calculating. But it is also equivalent to the LDL cholesterol plus the remnant cholesterol. And the atherogenic remnants are triglyceride-rich lipoproteins, and the triglycerides directly correlate with remnant cholesterol. If we are not able to measure remnant cholesterol, so the level of triglycerides directly correlates with remnant cholesterol. Remnant cholesterols, as I told you, are these components. They penetrate into the arterial intima. They don't need to be oxidized like the LDL, and they form atherosclerosis. There is an inflammatory component to these, and the triglyceride and the remnants are involved in the development of atherosclerosis by other pathways than by accumulation of cholesterol in the arterial wall. The fasting triglyceride is a serum surrogate for VLDL. In fact, VLDL we don't measure, we just divide the triglycerides by 5. And in the fasting state, 90% of TG is in VLDL. Triglyceride level is a good index for assessment of atherogenic lipoproteins which are of lower density than LDL cholesterol. Dr. Elliot Joslin, the father of diabetes in 1927, said, "I believe the chief cause of premature development of arteriosclerosis in diabetes, say for advancing age, is an excess of fat. An excess of fat in the body, an excess of fat in the diet, and an excess of fat in the blood. With an excess of fat, diabetes begins, and from an excess of fat, diabetics die. Being an Indian diabetic has high cardiovascular risk. The very fact that we are Indians, the ethnic risk gives us threefold higher CAD. If you are a diabetic Indian, threefold higher cardiovascular risk. Premature CAD, threefold higher. Diabetic dyslipidemia puts a threefold higher risk, cardiovascular risk, and hypertriglyceridemia increases this higher CV risk by another 33%. The prevalence of dyslipidemia, this is a very good study which showed in 300 known cases of angiographically proven CAD patients that in India we have a mixed dyslipidemia where the cholesterol levels are not so high but the low HDL is prominent and most of the people have high triglycerides. I will not go into this detailed causes of hypertriglyceridemia. I will just draw your attention to the second group, primary genetic susceptibility, metabolic syndrome, treated type 2 diabetes. And the secondary hypertriglycerides, excess alcohol, drug-induced, untreated diabetes, hypothyroidism, renal disease, liver disease, pregnancy. Hypertriglyceridemia causes macrovascular problems, micro, GIT, metabolic, hypercoagulability, and a prothrombotic state. Why is triglyceride important? It alters the chemical composition of VLDL. It makes the VLDL more atherogenic. It reduces the level of HDL and makes it smaller and denser. It increases the beta cell dysfunction and apoptosis. Insulinopenia occurs and the need for insulin is increased. Several studies have shown that LDL, HDL and triglycerides are all independent and significant predictors of CV risk. The Paris Prospective study in 1989 showed that plasma triglyceride was the only factor positively and significantly associated with coronary death. And Brewer later showed that elevated triglycerides contribute separately to the patient's risk of CV disease. Is hypertriglyceridemia an independent risk factor for coronary heart disease? Yes. Even Miller et al. Showed that even at a triglyceride level of 100, patients had a reduced chance of survival from coronary events. That is what in the earlier session I had mentioned, that it has been shown that even at a level of 100, there is substantial cardiovascular risk. Serum triglyceride as a risk factor for cardiovascular disease was studied in the Asia Pacific study. This is a very big study, meta-analysis of 26 studies, more than 96,000 patients, and they showed that there is a 70% greater risk of CHD. This is a meta-analysis of 29 prospective studies, more than 262,000 participants, and you can clearly make out that the hazard ratio are all above 1, nearer 2. The CHD risk is 1.86 for hypertriglycerides, and they indicate moderate and highly significant association. The emergence of triglycerides as a significant risk factor has been clearly shown. At each level of LDL, the triglycerides, if they are less than 200, the risk is less. The risk of CAD by triglyceride level, the Framingham Heart Study. This is a very important graph to see. What you will see here is the risk increases. The three arrows show that the risk increases at the level of 100 and goes on increasing up to almost 250, 300. And then the risk of CVD due to hypertriglyceridemia levels off. That means there is a factor which is causing increase in CVD risk from the 100 to 250 range. The Copenhagen City Heart Study, 31 years of follow-up, increasing levels of non-fasting triglycerides was similarly associated with stepwise increasing risk of myocardial infarction as with non-fasting cholesterol. The Prove It TB study showed that high-dose statin was able to reduce LDL to less than 70, and this was able to considerably reduce cardiovascular risk. This was studied by Miller, Cannon and Braunwald. This same group also studied triglycerides in the same number of patients, over 4,000 patients, and they showed, this is the first graph, is a proven study showing LDL less than 70 reduces cardiovascular events. And the second graph shows triglycerides less than 150 independently associated with lower risk of recurrent CHD events. This is not a sub-study. This is not a small study. This is the original prove-it study. And as you all know, the prove-it study and the heart protection study, these two major mega studies were responsible for changing guidelines to target LDL below 100 and below 70. The same group of patients studied, it was found that lower triglycerides were important, but that never translated into guidelines or practice. Elevated triglyceride is a cause for residual cardiovascular risk after intensive LDL cholesterol reduction even below 70. Does triglyceride reduction reduce cardiovascular risk? Major studies, the Veterans Affairs HIT study, the BIT study, the DARE study, the Helsinki Heart study all showed that reducing triglycerides reduces cardiovascular risk. The field study did not show so, but when a sub-analysis was done of the groups which had high triglycerides, there they found that there was a 27% reduction. The ACCORD trial was supposed to be a failure because it did not show any reduction of cardiovascular events with fenofibrate. But it was not done to study hypertriglyceridemia. When the sub-analysis of those same patients was done, they found a 31% reduction, which was very significant in cardiovascular risk by lowering triglycerides with fenofibrate. A meta-analysis of all these studies showed that there was a 35% reduction in cardiovascular events. Is the reduction of cardiovascular risk due to increase in HDL? No. If you increase HDL, it does not necessarily translate to better cardiovascular status. The AIM-HIGH study showed that there was no cardiovascular benefit, and the HPS2 Thrive study, increasing HDL with niacin showed no cardiovascular benefit. Lipid levels alter CHD risk, that we all know, and the modifiable factors for triglycerides, non-HDL, remnants are all the same. Control weight, increased physical activity, cigarette smoking, alcohol, high carbohydrate, hyperglycemia, medications. This is a slide I would like to show just one line. Many drugs increase triglycerides, and beta blockers, which are commonly used in diabetic patients for hypertension or for cardiac risk reduction, increases triglycerides by almost 25%. So do thiazide diuretics by 15%. There are a lot of drugs for reducing triglycerides. This is not part of my topic. It's just mentioning it: statins, fibrates, niacin, omega-3 fatty acids, and other drugs like metformin and 5-glitazole. So what is the strategy? Rule out other causes of secondary dyslipidemia, assess cardiovascular risk with the calculator, institute diet modification, exercise, weight reduction, counseling for curtailing alcohol, stop smoking, achieve good glycemic control, retest after 12 weeks, see if you have achieved the LDL cholesterol goal, initiate fibrates if triglycerides are high, even after achieving LDL goals with statins. Be vigilant for adverse effects because combinations cause problems. Review the response to lipid therapy every 4 to 6 months. The conclusions: Asian Indians have high CAD risk and further increased by diabetes. Premature CAD is highest in Indians. The Indian diabetic has atherogenic dyslipidemia. Several authentic studies have shown that high triglycerides is an independent risk factor. Treatment of high triglyceride significantly lowers CHD risk. Hypertriglyceridemia, especially deleterious for Indian diabetics. Lowering is beneficial even after an acute coronary syndrome. There is significant benefit in lowering triglycerides after LDL cholesterol of 70 mg or less has been achieved. Reducing triglycerides to low levels after achieving LDL goal in Indian diabetics can further reduce CVD risk by 33%. Thank you.